Thank you so much, Anandita, Gopi, the entire CSBC team for actually organizing this and having me here speak in front of such a smart audience. Uh, hope I'm able to do justice to the great speakers we've had all day long. And I'd like to acknowledge the guests of honors and definitely Sharon and Pavan, who've played an instrumental role, especially during my formative years at university as an economics student. I mean, we've come a long way since then, especially. I mean, back then, I remember incentivizing students to sign up for experiments in exchange of pizza to now sort of designing some of these incentive packages to drive statewide adoption of health AI. So I'll sort of spend the 15 minutes that I have walking you through the story that we've built at Cure and also try to attempt to draw parallels with some of the behavior uh, 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 sort of science perspectives, right? And I largely split it across three parts. I'll set some context, sort of share what we're building and what we intend to build. Uh, Talk you through some of the challenges that we've faced in adoption, and then move on to how we're solving for scale, right? So context, adoption, scale, and hopefully that should be it. But yeah, so a quick sort of intro on Cure and who we are. So we're a young medical imaging AI health tech company where we've been extensively developing and deploying imaging AI tools to detect early signs of critical illnesses like tuberculosis, lung cancer, COPD, PAH, etc. Right? The portfolio has been growing in terms of therapy areas, and I'll tell you how we pivoted to that. So we sort of started off as a health tech company wanting to leverage the data that was present and sort of solve using AI some of these challenges. And this is pre-COVID, right? Back when AI wasn't still the hype and the buzz. And that's where we sort of zeroed down on radiology, right? You might ask why radiology in health, right? And radiology was something that sort of uh, uh, was the first thing to be digitized, right? So across health systems, you see that radiology and digital imaging is something that's available digitally and data was available in abundance, right? Even now, we have health settings where EMR data and prescription data is still on pen and paper. It's not digitized yet. But if you look at imaging, it's always digitized. So we said we'll do radiology. And then within radiology, uh, chest x-rays was the lowest hanging fruit. We said that there are 1.3 billion chest x-rays being taken globally. They could be leveraged for something meaningful. So we said radiology, we said chest x-rays. And then when we solved for chest x-rays, uh, we looked at tuberculosis, right? Settings where TB was prevalent. And these are LMIC settings where the burden and the shortage of radiologists was prevalent. And that's why TB as a use case sort of picked up. So the tool that we sort of built then was an X-ray screening tool that could read, interpret, and report various findings, including tuberculosis, within like 30 seconds, right? And this was to be used as a secondary reader along with a radiologist. And in screening settings, it could then flag high risk TB patients who could then be tested um, for TB, right? So before the patients got lost in the community, you could collect sputum and do that, right? So we invested heavily in sort of uh, training the best model, ensuring that the model was easily deployable, right? So we developed a great tool that worked in the lab. We amassed a lot of data, made it generalizable, and that was great. Then we realized that it had to be deployable because health settings and infrastructures are not really even across the globe, right? So we had to double down on engineering. So our R&D and AI scientist talent helped build those models. We sort of doubled down on engineering, and then we sort of build models that could be easily deployable, and that could then create impact not only in sort of advanced health settings in the West, like the UK and the US, but also like Africa and settings where there was no PACS, no internet, etc. Right, and that's where we started sort of deploying in these settings, and we thought we've done it right. We started getting validation from WHO. We were in their catalog for best buys, and we were outperforming other AI models. And we thought that we've built a great product and it should scale automatically, but we were extremely wrong, right? We hit a valley of death. We said that we've built a great product, it's validated, it has regulatory clearances, but now what, right? Uh, right, in fact, if you see this slide, you'll be like, wow, you're creating impact in Kenya, you're screening patients for TB. But if you see that adoption is limited, it's only limited to the bare minimum requirements of the program, right? Programs that were only motivated to report for TB, they were not reporting nodules. And we at our HQ in Bombay in a cozy office. We're like, these scans all have lung nodules, and what are they doing about them? And health programs were not equipped nor incentivized to report for overlapping conditions with tuberculosis. And that's where we realized, and like Sharon very rightly sort of put it, right? AI was not about product, it's about people. And people don't operate rationally, they operate with bounded rationality. And we had to take into account what influences that bounded rationality, right? And if you take a step back, you see that healthcare as a problem is a multi stakeholder problem across time. So you have multiple stakeholders interacting across therapy areas, across geographies. So you have like millions of interaction points that needed to be accounted for, because knowledge was deeply uneven and incentives were distorted, right? And all of that with people in the center who were, facing cognitive overload, were risk averse, and were also guided by social preferences, right? So when we say cognitive overload, you have shortage of radiologists who are reporting those scans for their intended purpose. If there's a trauma x-ray, you just report the chest x-ray for the fracture and leave it. You're not going to look at the nodule, even in a Medanta back then, right? If you look at the TB settings, they report for TB and they leave it, right? So there was cognitive overload, right? They did not want to see more nodules because they did not know what to do with them. So we said we'll have a proprietary risk score where we won't increase the noise by reporting more nodules, because all nodules are not cancerous, rightfully so. So we said we'll have to also call out the risk score and say maybe out of all of these nodules, these are the ones that you should look at. So we tried to reduce the cognitive overload. We hired design thinkers to understand how radiologists were interacting with the product. And mind you, at this time, we were still solving for radiology, where we started acknowledging that we need to sort of move towards an ecosystem level and acknowledge stakeholders across the entire care pathway, right? So if we had to solve for lung cancer, we had to solve for pulmonologists, for thoracic surgeons, for oncologists, for everybody in that entire value chain, and then create that transfer of value. And that was super important. And if you look at risk aversion as a factor, it played counterintuitively, right? In LMIC settings, there was no penalty for quality of reporting, right? Radiologists are incentivized to report more number of images. That's it. How many images you report, that's the amount you make. But on a flip side, in the US, you have really steep lawsuits for malpractice. So we saw that risk aversion as an influencer played out positively for us in a certain setting, but negatively in the other setting. And of course, social preferences, where if health systems are not equipped with lung cancer pathways, they're not incentivized to again sort of report for them. With all of this context in mind, we then coupled the entire X-ray tool that I just showed you, which is trained on like 9 million scans, heavily validated, with a platform, right? So we said, let's build a Q-Track platform where we can sort of house all of these stakeholders who are interacting with each other, and meaningfully see if we can ensure that patients, because if you look at lung cancer patients, they need to interact with the health system. So they need to interact with multiple stakeholders at multiple time points to get the care that they need. So we had to document that and ensure that a person, right? So we went back from AI to people-led navigators. So we said we need navigators in place who then, you know, consume the technology, understand and act as a buffer with patients and doctors, right? So nurse navigators connecting radiologists to pulmonologists and ensuring that patients come back for their follow-up testing. And that's how we were able to sort of, arrive at a pathway-based approach. So now, from a medical imaging AI company, we started identifying ourselves as a uh, therapy area first medical imaging AI focused company, right? So we said we can't expect the systems to sort of solve for all the findings that we report for if we individually don't solve for it longitudinally. And so now let's move on to taking lung cancer as an example, right? So for lung cancer, we had to create hub and spoke models where satellite imaging sites had to be then mapped to hubs which were even more equipped with expert doctors and infrastructure to treat lung cancer. So we had to create a hub and spoke based model and ensure navigation of these patients was done via humans using an AI based app. So we were using AI to broaden the funnel, but we were using navigators to move patients across the care pathway. And this really worked for us. And we had to then sort of prove this. And we said we need a closed health system where we need to sort of show the entire loop closure. And our Goa model became pretty popular, and this helped us scale across the world that we did. I mean, with this particular sort of use case, right? And in Goa, because we got the support of the Minister of Health, we were able to sort of then deploy it across the entire state, where we created 3 hubs, one in North Goa, one in South Goa, and one in Panjim, and connected about 17 spoke sites to them. So we were now solving the problem operationally from a very rudimentary level using AI. So AI was not the center of how we were creating impact. AI was just a tool to broaden the funnel, right? Uh, and so we did that. And to our surprise and the surprise of the health minister, we were able to double the amount of lung cancers detected in that time period, right? So we detected 23 additional cases incidentally. So these are patients who don't have symptoms. So another factor of risk aversion is that patients don't want to show up at sites when they don't have symptoms, right? So AI, particularly when it flags patients incidentally, it's useful to then cause this state shift, right? Because in lung cancer, 80 to 90% of the cases are late stage, and you can only cause that stage shift when you can catch these patients incidentally. Because if you look at how as a society we are tackling a problem like lung cancer, we are trying to identify high risk groups, smoker populations, older populations, then screening them, which is a high effort activity, and it only sort of works for the high risk population. What about the young population, and what about the non smoking population who don't get access to these screening programs, right? We need to sort of again tap into the resource that chest x-rays are. And chest x-rays happen for any reason, like I said, right? Annual health checkups, xyz. So all of those x-rays needed to be leveraged, and then those nodules needed to be flagged and followed up, and this worked fantastically for us, right? And we said that, wow, I think this is something that will automatically scale up. But again, we hit the valley of death. We said that all of this was funded by strategic partners, and it's going very well, but what about sustainable scale, right? We we then figured that in order to sort of achieve a sustainable state in our mind, we had to really influence policy, right? And after the Goa model, we sort of got the flavor of policy and realized that if we have to scale across a lot of countries sustainably, policy is something that needs to work. So, like, if I have to put it in perspective in behavior science, what is a policy, right? A policy is a formal set of is a formalization of incentives. So when you formalize incentives, you get a policy, and incentives influence motivations, which then influences actions, and the collection of those actions is nothing but behavior change. So when you're looking at behavior change from a ground up level, while we acknowledged people to solve for adoption, we had to acknowledge policy change to sort of solve for sustainability, right? So that's how the dots sort of connected. And in order to sort of solve for that policy change, while it's easier said than done, you can build credibility very easier. You can signal credibility by the regulatory clearances that you have and by the impact that you're creating in the US, XYZ. So you can do a lot of things to show credibility. You can signal it, but you can't signal trust, right? You have to really do that by generating local context. And policy change can't happen based on credibility, whereas it can happen based on trust that can be emulated and demonstrated with local context. So you have to go to that local system, be it Thailand, Vietnam, etc., then prove that model works there on their population, and then prove a three-pronged sort of stool, right? It's clinical robustness, operational scalability, and financial viability. When you prove all of these three things, only then you see that states pick up and policy change really happens, right? Because once you've proven all this in that local context, there is no reason left for them to not adopt, not scale the technology. And that's what happened in El Salvador, right? El Salvador was a small country. We said we'll do that. We did that. And then now the Minister of Health personally is ensuring that, policies are passed so that every single chest x-ray taken in the country of El Salvador is screened using our AI tool, right? So the ideal state for us is that all 1.3, 1.5 billion chest x-rays taken globally must be screened using AI. And that's what happens, right? So you can always compete at a product level, but you have to collaborate at an ecosystem level in order to create change like this, right? So you have to share those learnings, understand what's happening, and then replicate those models across all of the countries to create that change, right? And yeah, so we started off with a very myopic view on product and AI, but I think we've sort of evolved from there into a place where we now know that without policy change, sustainable sort of impact will not happen. And now we're dabbling our way through building trust across systems, and only time will tell whether this will stay or we'll get acquired by someone, and all of this will get consolidated by bigger players, right? So uh, that's that. And on what's next, I also wanted to show that, so now we spoke about broadening the funnel, we did all of that, and like I said, we had to impact the pathway longitudinally. So we started impacting detection, diagnosis, and now we're also moving towards impacting treatment pathways and sort of optimizing treatment, right? And how we're doing that is now we're using AI to sort of impact clinical trials where we're understanding if we can standardize how disease progression and treatment monitoring is sort of reported. And uh, I was fortunate enough to sort of uh, work with Otsuka on their phase 3 trial, which has now been accepted at the union, where we'll share more of our findings on how we did that. So we co-authored some of the work around that, where Otsuka is working to develop a sort of newer treatment regimen that reduces the traditional 6-month WHO prescribed regimen to 4 months, right? And in order to do so, they have to prove efficacy. And when they do that, they have to show that, conditions are becoming better, treatment is working, and they have to standardize it because radiologists report cavities and TB as a condition very sporadically, right? So AI is also now playing a role in optimizing treatment for those patients and then closing the entire loop from presentation to cure, right? So yeah, I mean, that's my time. Happy to take up questions if you have some time left.